Cass was going to speak to you on the hereditary component, the link between breast and ovarian cancers. And I do touch upon the breast cancers a little bit. It's virtually the same talk, but for me, I have spoken on this topic before, and I just wanted to take the opportunity to talk from my own slides so that I can be very genuine with you. So you don't have those in your booklet. So I apologize for that, but I'll speak to the staff and see if there's any way we could make copies available at some point. But I just found out I was doing this 2 days ago, so I apologize. The booklets were already pre-printed. But that being said, I did come all the way here from San Diego to be with you here today. And you guys have San Diego weather. What is going on here? I wore like this heavy, I was all excited to get to wear my winter outfits, and no. But anyway, thank you very, very much for all being here with us today. So ovarian cancer, and Dr. Fowler just spent a lot of time on the details of ovarian cancer and how it's not one disease. So I won't belabor these points, but I do want to highlight a few things that he talked to you about. And is the audio better over there now? Okay. There are over 21,000 new cases that were diagnosed in 2011, and that's about a 1.4% lifetime incidence for women. Ovarian cancer is the second most common gynecologic cancer, and it is 3% of all female cancers in the United States. It accounts for more deaths than all other gynecologic cancers combined. And 70% of women present with advanced stage disease, so stage 3, stage 4 disease. So again, as Dr. Fowler was saying, we do a really bad job in screening for this cancer. It's not that we don't do well when we diagnose it early. In fact, we do. It's just that unfortunately most women are presenting in the more advanced stages. The types of ovarian cancer, again, just to briefly review, there's epithelial ovarian cancer, and that's the cell type that is the most common. It's about 90% of the ovarian cancers that are diagnosed, and it accounts for the majority of the deaths. It's also the most common type of hereditary ovarian cancer, which will be the focus of my talk today. Germ cell tumors, on the other hand, account for only about 5 to 10% of ovarian cancers. And they're more common, and most common, I should say, in adolescent girls and young women. So girls that we know start their periods very early, maybe have breast development early. I'm talking about very, very early, 7, 8 years old. Sometimes they have tumors that are actually producing estrogens and causing those other symptoms. And those are usually germ cell tumors. Stromal tumors are about 5% of ovarian cancers, and again, much more rare and more curable. Risk factors for epithelial ovarian cancer, or what I will abbreviate for you as EOC, so that I don't get too tongue-tied up here. Increasing age, so the risk actually continues to rise over the course of a woman's lifetime. This is a little bit different than the hereditary breast cancers, where we always talk about how having a premenopausal breast cancer is a red flag for having a hereditary component. With ovarian cancer, even the hereditary components can occur over the course of a woman's lifetime. So the fact that you had ovarian cancer before menopause may be concerning, but it doesn't mean you're not at risk for a hereditary component if your ovarian cancer occurred after menopause. A personal history of premenopausal breast cancer, so again, breast cancer that occurs usually before age 50 years old, is a red flag for possibly being at risk for ovarian cancer. Nulliparity. So what do we mean by nulliparity? We mean women that never had children. Now, this is kind of one of those tricky risk factors, because there are women who chose not to have children. Maybe they were on birth control pills for a very long time, or maybe they just didn't want to have children. Their risk factor profile is a little bit different than somebody who perhaps tried to conceive but couldn't. And so when we say that nulliparity is a risk factor, we're actually talking about the women that had problems conceiving. Family history of epithelial-associated cancers. These include epithelial ovarian cancer, fallopian tube cancer, primary peritoneal cancer, premenopausal breast cancer, or male breast cancer. And then, of course, a known genetic mutation. So your family or someone in your family is carrying a gene that we know predisposes to ovarian cancer. More commonly, we're referring to the BRCA families or the HNPCC, or what's also known as Lynch families. Why is evaluating genetic risk important? Well, there may be a risk of other factors, and there are screening programs available if you're at risk for other cancers, including breast cancer. You know, one of the main differences between how we do with breast cancer and how we do with ovarian cancer is the fact that screening actually works for breast cancer. Screening doesn't work for ovarian cancer. So women that are known to be at risk for breast cancer are put into screening programs that actually have been shown to reduce the disease incidence. That's not the case with ovarian cancer. So evaluating genetic risk is important because screening programs are available that may be able to decrease your risk of developing additional cancers. We also want to identify family members who may be at risk, as well as those who are not at an increased risk. You know, information is empowering. Finding out you have a gene may be alarming, it may be disconcerting, but it also can give you information that you then feel you can make smart choices about. Finding out you don't have the gene also may prevent you from going into unnecessary screening programs and unnecessary worry. And genetic testing may be possible, not in all cases, but in many cases it is. And then, of course, we can implement certain risk reduction strategies. The commonality of familial and hereditary cancers. Most people think that when we talk about hereditary cancers or familial cancers, we're actually talking about the same thing. In fact, we're not. In medicine, when we think about taking care of patients that have a familial risk, we're actually talking about a group of patients that's different than patients that have hereditary risks. The simple sort of tagline, back of the envelope take-home message on this is familial cancers tend to be the ones that run in families, but that we haven't necessarily identified a gene for. So you may hear of someone who's got shared genes, environments, and lifestyles, and that, gosh, there seems to be an awful lot of cancer in that family. But when we sit down and we go through the family history, we actually can't tie all those cancers together by one particular gene. Yet we are highly suspicious that there's something going on in that family, and so we call that a familial cancer family. On the other hand, when we talk about hereditary cancers, we're talking about 25% of all ovarian cancers. You heard me right. In the past, when I've given this talk, I've talked about 10% of ovarian cancers. Well, now we actually know, and we've identified more genes, that that risk is about 25% of all ovarian cancers. And it's about 5 to 10% of other cancers. Syndromes that are known to be associated with specific genetic mutations are termed hereditary. And the inheritance is usually autosomal dominant. What does that mean? It means you've got a 50-50 chance that you got that gene from one of your parents. And that also means that there's a 50-50 chance that you're going to pass on that gene to one of your offspring. Penetrance, on the other hand, can be variable. So the actual expression of that gene is variable. There are families that I take care of that one of the women will actually get the ovarian cancer, and perhaps a sister has the gene, but she's never actually expressed the gene. Now, we'll talk about risk reduction strategies going forward, but it doesn't necessarily mean that you're going to get the cancer just because you got the gene. Is a genetic cancer syndrome likely? What should you be looking at in your family to raise those red flags? Well, is there an early age at cancer diagnosis in anyone, males or females? Remember, when we're talking about ovarian cancer risk, we are talking about women, but the genes themselves can come through the men in the family. So don't just be looking at the women in your family, take a good, strong look at the men in your family as well. Cancer diagnosis in 2 or more first-degree relatives on the same side. So you want to take a good, close look at your maternal side and a good, close look at your paternal side. Combination of cancers indicative of a specific syndrome. So breast and ovarian, are those occurring on one side of the family? Colon and endometrial, that's another syndrome called Lynch syndrome. Thyroid and breast cancer, that's another syndrome called Cowden syndrome, but it can actually predispose you to a variety of malignancies, and again, not just in the women. Multiple primary cancers in a family, and multiple rare cancers. So how is it exactly that you inherit a risk that predisposes you to cancer? Well, all of us, inherit 2 copies of each gene in our body. 1 copy from our father, 1 copy from our mother. And in someone that has not inherited a genetic defect, both copies are normal. So in order for this to progress to cancer, you first have to knock out 1 copy, and then you have to knock out a second copy in order for the malignancy to develop. In someone that's inherited a gene, however, that's defective, they don't have 2 normal copies. They start with 1 copy that's already defective. So they only have to undergo 1 more hit. I mean, it's a bit of a simplified version, but it doesn't take as many events for them to develop cancer as it does somebody who is born with 2 normal copies. And this is commonly termed Knudson's 2-hit hypothesis. So if you're born with 2 normal chromosomes, you got to knock out both to get the cancer. But if you're in a family that has a genetic alteration, you only need to knock out 1 because you only have 1 normal copy. So hereditary cancer syndromes that are commonly studied include the HBOC or the BRCA syndromes, and BRCA1 and 2, as well as 10 other less commonly known genes, are all responsible for this breast ovarian cancer risk. Lynch syndrome, or HNPCC, these genes, collectively called the mismatch repair genes, they're responsible for the development of endometrial, colon cancers, and some other more rare malignancies, including ovarian, but with a less high frequency. Cowden syndrome, that's the PTEN gene, that's the breast and thyroid cancers that I talked to you about, and some endometrial cancers. FAP, it's the APC gene that's responsible for these. And then other syndromes that are much more rare include Lee-Fraumeni and von Hippel-Lindau, and those genes are the P53 and the VHL gene. So less frequent, and the majority of what we're going to focus on today will be the HBOC syndromes. So what is the story of BRCA? I mean, I like to give a little historical background on this because I think it's, you know, it kind of tells you how rapidly things can actually develop in medicine. In 1990, Mary Claire King and her colleagues announced that they had localized a gene that was responsible for hereditary breast cancer. And the gene was termed BRCA1, and they found it on chromosome 17. In 1991, so just a year later, Mark Skolnick founded Myriad Genetics. And basically, there were several labs in the country that launched a race to try to identify and sequence this gene. And the actual history of what happened, I think, is very interesting. So in 1990, the gene gets identified. Myriad Genetics, which you know is a private company, launches in 91. And then by 94, Myriad actually sequenced BRCA1 and filed a patent, which is why you couldn't get tested for this gene without paying a significant amount of money until insurance companies started to agree to cover it. In 1995, Myriad filed a patent for a second gene called BRCA2. So in fact, when we're talking about BRCA1 or 2, we're talking about 2 separate genes in which there are over 300 different mutations. And that's part of the reason that not everybody is at the same risk for developing ovarian cancer just because you have the gene. Because each different genetic mutation confers a different risk of getting either breast or ovarian cancer. And then by 1996, Myriad made the testing widespread available. Basically, you send in a blood sample and you could get screened for either BRCA1 or 2. But again, at significant costs. The current state of genetic testing, and this is evolving, is that Myriad now can sequence your entire BRCA1 and 2 genes for a cost of about $4,000. Other tests are actually likely to become commercially available, as in I think it was April, the U.S. Supreme Court actually just decided, I say just, but I do think it's important and it is new. The U.S. Supreme Court decided that Myriad did not have the right to patent a human gene. They could patent the test that they were doing, but they don't have a right to patent a gene that we all carry. And yet that is how they were able to charge such a high rate and not have other commercial tests available for what they were doing, for sequencing those genes. The current state is that actually we can identify about 85 to 92% of all mutations. And in 2006, Myriad added what's called rearrangement testing to their panel, and that they charged an extra $700 for, even though basically what they were saying is the testing they were doing before was incomplete. And so what the BART testing, which is the rearrangement testing, does is it's looking at the genes, and all the components of the gene are there, and they're not mutated, they're just in the wrong order, which means that gene can't be translated properly. So if you had your testing done before 2006, you should actually consider speaking with your genetics counselor or your GYN oncologist and be retested if you were negative, if there is a high index of suspicion that there is something running in your family. The yield is not all that great. It tends to be a little bit higher in Hispanic and Asian families that were negative. But again, it's something to note that the testing is always evolving, and it's one of the reasons that you really do want to be linked in with a genetics counselor or a GYN oncologist so that you can be in some sort of registry so that as things evolve, as the testing changes, you could still be contacted and made aware of things as they're evolving, because it might impact your family information. So hereditary susceptibility to ovarian cancer. Until recently, we thought that only about 10% of ovarian cancers were inherited, and almost all of that was explained by mutations in BRCA1 and 2. With the advent of new next-generation sequencing, which is the ability to sequence the human genome or portions of the genome at a much more efficient, cost-effective way, we now have new technologies that allow very rapid testing with less expensive DNA sequencing. And so it's actually easier now to sequence many genes at once rather than going back and sequencing just one gene. To be honest with you, in 1998, I was in the lab of Jeff Boyd, who's a board member on the foundation, and we used to have these huge glass plates, like this big, that we poured gels in, and we would sequence the DNA, and it would take us days, and then we'd sit there and count every little A, C, T, G, A to see whether or not there was a mutation. I mean, that's how those things have changed to like cute little machines like this now versus, 20 years ago, well, yeah, 20 years, 30 years ago? No, 20 years ago. I was not that young in med school. So 20 years ago, just doing all of this on big glass plates, a very cumbersome process that you can imagine was hugely expensive. So because the technology is changing at such a rapid rate, it's actually making it much more cost effective to be able to sequence large portions of genes. And with that, we're finding out that many more genes are actually responsible for the hereditary component of ovarian cancer. So this is just a little moment of levity. Genome Henderson, we're working on the human genome, and he brings in a little gnome. So again, to my point, the cost of obtaining DNA information is decreasing faster than the cost of processing data on computers. And so basically, in 2001, it was $100 million to sequence what now costs about $10,000. So $10,000 is still a lofty amount of money, don't get me wrong, but I think you can get a feel from this graphic how, as the cost goes down, we're able to get more and more information out of DNA, and learning is exponential in terms of the amount of information that we're able to gather. So that's basically how the group at the University of Washington has been able to discover that we now know there are many more genes that are inherited that are responsible for passing on the risk of ovarian cancer. And the BRCA technology is what the University of Washington group is using, and it allows multiple cancer genes to be sequenced at once. And so what they did was they had actually been collecting tumor samples on women for a very long time, and they performed this genetic analysis on a series of over 300 women. And in that analysis, they found 11 additional genes that were responsible for hereditary ovarian cancer. And so now we know that we've moved from thinking that 90% of ovarian cancers were sporadic or just incidental to only 75 are sporadic, which means that about 25% of ovarian cancers are inherited. This is a huge jump, and I think that it's actually a huge amount of information that's going to ultimately allow us to identify women at risk earlier in the process. So these genes, just to show them to you, are, again, 70% of the hereditary risk is covered by BRCA1 and 2. And then you have this other group of about 11 genes so far, and I say 11 because it's probably 11 plus. Again, with more and more analysis, we're learning more. And these are responsible for about 30% of that inherited component. But these genes each occur in a much lower frequency than BRCA1 and 2. So right now, they're not commercially available. It's not like you'd walk in to your doctor's office and say, hey, can you test me for CHEK2? That's just not something that we would do without doing a very thorough family history analysis, and then having still a very high index of suspicion that there is a genetic risk in a family that's otherwise BRCA negative. HNPCC, in the 4 genes in that family, account for less than 1% of the inherited ovarian risk. And so to date, 17 genes have been identified as being responsible for hereditary ovarian cancer. A couple of the important clinical findings that came out of that University of Washington study were that, first of all, 30% of women that had inherited mutations in their genome had no prior personal history of breast cancer or family history of breast or ovarian cancer. 30%. So when you speak with your doctor, and current NCCN guidelines are actually that all women with ovarian cancer be screened for a genetic mutation. That's different than the breast cancer recommendations. It's partly because of this finding. So if 30% of women that have ovarian cancer have no family history of breast cancer or ovarian cancer, yet they're carrying a gene, we need to know that. We need to start, identifying these women at risk because it matters for them for other cancers as well as their offspring. And 37% of women with inherited mutations were diagnosed with their cancer after 60. Remember what I said to you earlier about just because you get to menopause and you didn't get the ovarian cancer doesn't mean you're not at risk for actually carrying a mutation or developing the malignancy, because the ovarian age profile is very different than the breast cancer age profile. So can we test women for all these genes? Costs a lot of money. And insurance companies are not necessarily, going to pay for all this. I mean, most of them are paying for testing of the BRCA1 and 2 genes, but they're not testing for some of these other profiles they're not paying for some of these other profiles that are available. I mean, the high cost and inefficiency of single gene testing in the past is impractical. I just showed you, 17 genes. That's a lot of money that has to go into testing. We have to continue to work on making the technology more efficient and lowering the costs associated with that in order to have all of this technology available to our patients. Gene patents inhibit the development of comprehensive multi-gene panels. I don't exactly know where this is going to go with the Supreme Court decision, but I think that ultimately it will help lower costs as well. Currently, there are other panels besides BRCA available. Ambry Genetics has a couple of panels depending on what your individual cancer risk seems to be. And the University of Washington also has a couple of other panels, and they test for various genes. But again, those are not ones that you would just want to walk in and pay $4,000 for. You really want to be seeing a professional, either a genetics counselor or a GYN oncologist that's very familiar and comfortable with taking care of patients with hereditary cancers to assess your risk so that when you do lay down your money, you're laying it down wisely. So first steps, again, I can't emphasize this enough. Consult with a GYN oncologist or another physician very familiar with hereditary cancer risk. always, always, always see a genetic counselor. I cannot tell you enough how, like, yeah, you can have your blood drawn, you can swab your cheek, you can send the testing off, but if there's nobody there to counsel you on what that test means when you get it back, then it's not, it's useful information, but it's not as useful as it could be. Because a negative test may mean that you're not at risk, but maybe your family didn't have that gene to begin with. And a positive test doesn't always mean that you're going to get the cancer. So avail yourself of the counseling services that are part and parcel of the testing. Don't just do the testing. Evaluation of family history. This is where I say you get to be the family detective. Talk to everybody in the family. Find out who had cancer, who had a hysterectomy and had their ovaries removed in their 30s so that it looks like the cancer skipped a generation. These are important facts to consider. Where did the cancer start? You know, patients say, oh, so-and-so died of liver cancer. Well, maybe that was a metastasis. Where did the cancer actually start? And what age was the diagnosis? Did somebody have more than one cancer? And are the pathology reports available? You know, with the BRCA cancers, those are high-grade serous cancers. With the Lynch syndrome cancers, those are mucinous cancers. And these will help focus your detective search in a better way. And consider previous cancer history. Has anybody had any other type of cancer? Cancer genetics counseling. Usually when you see a genetics counselor, this is an in-depth interview. They're going to consider both your maternal and paternal sides. They're going to go back 5 generations if you have enough information. And they're going to ask you to bring medical records if it's possible. They're going to go through your personal and family risk assessment. They're going to identify members at risk. And is genetic testing possible? They're also going to address family communication and insurance issues with you because these can be tricky. This is part of the very difficult part to navigate. Some people want to be tested and maybe they have a sibling that's like, whatever you find out, I don't want to know. I don't want to live my life that way. These are individual choices and they're dicey issues and you can't assume that the way that you react is the way that other families are going to react. Decision for genetic testing, again, personal and or family history with features suggestive of a hereditary cancer syndrome, the ability to accurately interpret a test result. The best person to get tested is somebody who actually had the disease. That person's called a proband, because if that person is positive, then that's an informative test, and then you know you can go on and test other people in the family. If that person's negative, there may be no point in continuing to test other people. Autosomal dominant inherited mutations don't skip generations. You either pass the gene on or you don't. It may be that the cancer skips generations, but the genetic transfer does not. Perceived risk to benefit ratio. Again, this is a very individual issue. And the ability of the test result to affect medical management. Maybe you need to be in a breast cancer screening program in addition to the fact that you're in your ovarian cancer surveillance program right now. Psychosocial readiness, do not underestimate this, as well as cost considerations. Benefits of testing, a negative result can confer a sense of relief or elimination for special management. A positive result, some people feel like, okay, now I know what I'm dealing with. It's relief from uncertainty. It allows informed decision making and taking steps to reduce your cancer risk. And there's opportunities to consider participation in medical research trials. The risks of genetic testing, there's few real medical risks. I mean, most of the tests are a blood draw or a cheek swab, but the test can have broad range of impact on emotional issues, privacy, confidentiality, childbearing choices. Positive results can have big psychosocial issues, including tension in families, and negative results, and I've seen a few of my patients, they have survivor guilt. They're like, well, I didn't get it, but my sister did, and you know, where does that leave us? So these are not easy waters to navigate, and I again encourage you to avail yourself of the medical professionals that can help you with that. Risk-reducing strategies, there's surveillance, chemoprevention, and prophylactic surgery. Surveillance, bottom line is the current NCCN guidelines are that you should have a routine pelvic examination every year. You should have CA-125 and transvaginal ultrasounds to look at the ovaries and the fallopian tubes every 6 months. And starting at 30 to 35 years old or 5 to 10 years earlier than the earliest age of the first diagnosis of ovarian cancer. Unfortunately, none of this has been shown to reduce the risk of developing ovarian cancer or to increase our ability to diagnose it at an earlier stage. So, we know that stage is important to survival. The earlier you can diagnose ovarian cancer, the better the patient's survival. So what are we doing right now about this? There are just hundreds and hundreds of researchers trying to develop better screening programs for ovarian cancer, but basically what this has left us with is chemo prevention and risk-reducing strategies, because we actually cannot seem to find a screening test just yet that can make a difference. So what sort of chemo prevention are we talking about? Birth control pills. Women that have taken birth control pills for 5 or more years of concurrent use have up to a 60% reduction in the development of ovarian cancer compared to their peers or counterparts that never took birth control pills. So the keys seem to be that 5 years or more of concurrent use, okay? And we think this has something to do with suppressing ovulation. So this goes back to when I talked to you earlier about nulliparity. Remember, someone who's been on birth control pills and that's the reason they haven't had a baby is a very different risk profile person than someone who tried to conceive and couldn't. And the reduction in risk for ovarian cancer seems to be by about 5% for each year the pill was taken. So if you only took it for 3 years, it doesn't mean you didn't get any benefit, but really we're encouraging women who haven't yet completed their childbearing and yet want to retain their ovaries to be on the pill until they're actually trying to conceive. Prophylactic surgery, this is removal of the healthy fallopian tubes and ovaries before the cancer develops, ideally upon the completion of childbearing or by age 40 or 5 years earlier than the youngest age of ovarian cancer in that family. Presently, there are no recommendations on removing the uterus. Uterine cancers do not seem to be related to BRCA1 and 2-like mutations. This results in a 96% reduction in risk of ovarian and fallopian tube cancer. It does not change your risk of primary peritoneal cancer, okay, one way or another, which is the cancer that arises de novo from the lining of the abdominal cavity. But it does reduce the risk of breast cancer if you have the removal of the tubes and ovaries before menopause. And some studies have shown that that risk can be as high as 50 to 60%. Occult cancers in high-risk women, so this is women that are taken to the OR, presumably to have healthy tubes and ovaries removed, and they find a microscopic cancer in those ovaries. That risk in various centers has been reported at 2 to 23%. That's why when you have your ovaries and tubes removed for prophylactic reasons, you don't want to just do it in any old hospital. You want to do it in a place that's used to looking for occult cancers, because you want the entire ovary and fallopian tube submitted for analysis. We call that serial sectioning. I probably do about 6 to 8 of these a month on patients in my practice, and these are the patients who can never sign up for like just tissue donation for some other study, because I want every single little itsy bit of their ovaries and fallopian tubes submitted to pathology to look for an occult cancer. So if you have this done at just like some hospital that's not used to looking for these, then they actually usually only take 2 or 3 sections from your ovarian tube. So they may miss something. So make sure you have this done at a center that's familiar with taking care of hereditary cancers. So in conclusion, ovarian cancer accounts for more deaths than other gynecologic cancers combined. We now know that approximately 25% of ovarian cancers are inherited, okay, not the prior 10% we thought before. And 30% of women with inherited mutations had no prior personal history or family history of breast or ovarian cancer. Genetic testing needs to be available to all women at high risk, but gene patents and testing costs have prevented widespread availability. Screening high-risk women has unfortunately not been shown to lead to an earlier stage at diagnosis. However, chemo prevention and prophylactic surgery have led to improved survival. Thank you very much.